Okay, good morning, everybody. I'm Ryan Leone. I'm one of the chief residents. On behalf of the Department of Pediatrics, welcome to Pediatrics Grand Rounds. Dr. Mary Leonard was unable to join us today. We always begin with our there's great vibes in the room today. We always begin with our landing acknowledgement that we sit on the ancestral land of the Muwekma Ohlone. And before Dr. Golden introduces our exciting speaker today, some quick housekeeping. I'll talk on the next slide about Dr. Devika Bhushan's wonderful keynote next week. And the following week, we have Dr. Ng from the University of Toronto. But to jump back, so next week is our Diversity and Inclusion Forum. In lieu of Grand Rounds in LKSC, we'll have the keynote address by Devika Bhushan, who's the former acting Californian Surgeon General. Okay, be sure to text your code for attendance, and I'm gonna pass it off to Dr. Golden to introduce our speaker.
Thank you, Ryan. So much energy so early in the morning. So welcome, everyone. This is great. So it really is a true honor to introduce our guest speaker today, Dr. Scott Hadland, who's Chief of Adolescent and Young Adult Medicine at Mass General Hospital. He is Associate Professor of Pediatrics at Harvard Medical School, and he is triple boarded in pediatrics, adolescent medicine, and addiction medicine. He really is one of the leaders in the field of substance use disorder, and he's known nationally and internationally for his work. He has published his work in the New England Journal of Medicine, the Lancet, and also Pediatrics. And also he's been interviewed for articles, the New York Times, the Washington Post, CNN, as well as other news outlets. In 2020, he was the recipient of the American Academy of Pediatrics Emerging Leader in Adolescent Health Award, which is a true testament to his work and the importance of his work as well. In 2023, this year, he was selected to be a Presidential Leadership Scholar, and this brings together national leaders committed to facing critical challenges in partnership with the Clinton Presidential Center and George W. Bush Presidential Center. He has been funded by the National Institute of Drug Abuse, the CDC, and American Heart Association. And the topic of his talk today is how pediatric workforce can address the nation's overdose crisis. Welcome, Scott.
Thanks so much. It's really great to be here, and I will try to keep the energy up. That's a tall order for the next hour because we really got it high there, didn't we? So thanks so much for having me. As Dr. Golden just so nicely said, thank you for that wonderful introduction. I work providing adolescent addiction care, and the way that I do that at Mass General is we have a clinic, a primary care clinic, where we really try to provide addiction treatment as part of the primary care that we deliver. And so, I will be seeing a patient, and sometimes, the goal of the visit is for me to help treat their struggles with nicotine or their problems with alcohol or their opioid use disorder. And what the patient's real sort of goal for being there is to have their acne treated. And what I really like about this model is that it takes addiction, which has so historically been siloed and separate from what we do in pediatric care, and kind of brings it in the door and makes it part and parcel of what we do. And so what I'd like to do today is spend the next hour talking about real concrete ways that we as a pediatric workforce can try to incorporate some of these details into our own work. Look, we don't all have to be addiction subspecialists, but there are certain things that all of us can do. And I really want to try to empower you because many of these things are really easy and can be really pivotal and in some cases life-saving. So I have no conflicts of interest to disclose. And I want to start with a story. I want to tell you about Zach. Zach was a 17-year-old boy living here in California in Sacramento. And this is a picture of him and his mom, Laura. I've gotten to know Laura over the last year through advocacy that we've been doing at the national level around fentanyl overdoses. And Zach was a teen who was thriving. He was really successful at school. He got admitted to UCLA. He was planning on studying psychology, wanted to become a clinical psychologist. He was the star of his high school plays, and he had a ton of friends. And like many teens, when COVID hit, he sort of got isolated from everybody. It was a really tough time. And one day he and one of his friends tried a pill that they had bought off of social media. And they used the pill. And a couple days later, Zach thought, I'm just going to try one more time. This will be the last time. And he used alone this next time. And he ultimately ended up taking a counterfeit pill that contained a high amount of fentanyl. And he died at home. And his dad was there and was unable to resuscitate him in time. And unfortunately, Zach was one of what is now amounted to the equivalent to a high school classroom of teenagers who die every week across the country from overdoses, the majority of which are caused by fentanyl. And so even though addiction has historically been siloed away from what we do in pediatrics, and even though we've been a workforce that for much of the early lifespan kind of can get away without talking about some of these issues, this has become one of the most pressing public health issues of our time. And there are things that we can do and now we need to do to take this on to help families like Zach's and prevent this from happening. So my objectives for this talk are really, first and foremost, to just really highlight the ways in which children and adolescents have not been spared from this national overdose crisis that we hear so much about. And by the end of today's talk, I want to make sure that I have described the epidemiology of substance use related harm in the US, focusing on youth, who I think sometimes are left out of our national narrative. Two, to talk about how we can prescribe opioids in a way that reduces the likelihood of risk for long-term opioid use and addiction, because these are things that we sometimes do in pediatric practice. And then third, to ensure evidence-based screening and treatment for youth with substance use disorders. And amid that, we'll talk a little bit about harm reduction and overdose prevention. So starting off with this epidemiology, just to give an overview of where we are with all age groups across the country. So this is not just young people, but also adults. The most recent year for which we have full data is 2021. And this is what the map looked like across the United States. So states that are shaded in darker colors here are states with higher overdose rates, and states with lighter shading have lower overdose rates. I'll say that California has had a big change. California has traditionally been a state that has had overdoses, absolutely, but the burden of these overdoses is really picking up in a number of places here in California, including in the Bay Area, including in around Los Angeles, including in around Sacramento. And even though it sort of appears a lighter shaded blue here in this figure, be on the lookout because rates are going up quickly here. And in particular, it's again because of fentanyl, and in part because of these fentanyl contaminated counterfeit pills that we'll talk about today. And if you look at all age groups, we're now at a point in the United States where we've hit a historic high. More than 100,000 people across the US die every year from an overdose. We've had more than 1 million overdoses since the turn of the century. And this all amounts to, right now, every 5 minutes across the United States, someone is dying of an overdose. And so I think the key questions for us as a pediatric workforce are to ask, first of all, well, what's happening with youth overdose rates specifically, and which opioids are involved? What percentage of youth use opioids non-medically? When does opioid use rise to the level of a formal diagnosis of addiction? I told you about Zach before. Zach had just used opioids twice that we know of. And I wouldn't call that addiction. I would call that experimentation. But at some point, experimentation and ongoing use turns into addiction. So I want to talk about how we identify that, what that transition looks like. And then last of all, what are the neurobiological underpinnings of addiction? Because I think that, at least when I was training in medical school, this is something that was very glossed over, and our understanding has really evolved in recent years. So here's what's going on among teenagers and overdoses across the country, and it's really alarming. So this is a figure using national data from the CDC that was published last year. And these data run from 2010 on the left to 2021 on the right. And there's a few different lines here. Each of these lines sort of represents different drugs contributing to drug overdoses among teenagers aged 14 to 18 in the United States. And you can see that for most substances, the lines were relatively flat for a long time and stayed so. But in the United States, in sort of the mid-2000 teens, is when we started to see fentanyl enter into the drug supply. So fentanyl is a highly potent opioid. It's at least 50 to 100 times more potent than heroin. And of course, we use fentanyl medically, particularly in anesthesia and other parts of our medical practice from time to time. But this fentanyl is illicitly manufactured, typically manufactured outside of the country and then brought in. And as I'll talk about in a moment, has really permeated all different parts of our drug supply. Heroin now is more likely in many places than not to contain fentanyl and not entirely heroin. The cocaine drug supply sometimes gets cross-contaminated with fentanyl, and so people overdose when they think that they're using cocaine, but instead are exposed to a highly potent opioid they weren't expecting. And then counterfeit pills, which we'll talk about in a moment, are commonly laced intentionally with fentanyl. And so with this as the backdrop, what you see is that starting in about 2017, 2018, 2019, you see this rise in overdose deaths among teenagers that's really attributed to this gray line, which is illicit fentanyls and synthetics. And this is the whole family of sort of opioids that includes fentanyl and its derivatives. And what you see is that with this dotted line, we have the onset of COVID, and all of a sudden just a huge skyrocketing in the number of teens dying nationally from fentanyl overdoses. And so fentanyl, in fact, actually, I see here fentanyl is now involved in about 75% of all overdose deaths in teens. More recent data actually tell us this is probably even higher, closer to about 90%. But it's worth knowing that even as we sort of singularly talk about opioids and fentanyl, that actually if you look at the data, particularly for young adults and older adolescents, most overdose deaths actually involve opioids plus another substance, that cocaine is commonly involved, benzodiazepines are commonly involved, and methamphetamine are commonly involved in overdose deaths. And so I just want to highlight that even though today we'll be talking a lot about opioids, there is this sort of polysubstance problem that's going on in the United States, particularly as you enter into the adult years. Polysubstance use really becomes the norm when you look at overdose deaths. And if that hasn't convinced you that youth really matter in this crisis, I just really want to drive home that this is addiction and opioid use and misuse are really pediatric onset conditions. If you talk to adults who are in treatment for opioid addiction, 2 out of every 3 will tell you that the first time they misused an opioid was before age 25. And 1 out of every 3 will tell you that they first misused before the age of 18. So this is a condition that's starting during the childhood years, the years that we care for. And then if you look at national data about how many teens are misusing opioids, it turns out that our national surveys don't always do a great job of finding out exactly what teens are using. This sort of the questions sometimes lag a little bit behind the epidemiology. But one of the better questions that we've got, because this actually is what happens most commonly, is that when teens are experimenting, they're usually experimenting with prescription opioids or what they perceive to be prescription opioids. And so if you survey high school seniors across the United States, which is what we do with surveys like Monitoring the Future, which is what is listed here, and you ask the question, how many high school seniors have used or misused rather an opioid for non-medical purposes? What you'll see is that the percentage kind of reached a peak in the early 2000 teens. Actually, we got to a point where there was about 1 in 8 high school seniors who had misused a prescription opioid in the survey. And very fortunately, that number did decline over the 2000 teens, right up to 2021, the most recent year for which we have data. But I'm really concerned because if you look at the data from pre-COVID, so we actually have some data from just before COVID hit in 2020, that proportion was still about 1 in 19 high school seniors had misused a prescription opioid in their lifetime. And that's about 1 to 2 students in a typical high school classroom. So even though we've had this decline, it's still really high. And this is on the order of the prevalence of many other conditions that we as pediatricians are much more familiar with, right? Like asthma or diabetes, things that we think about and work through all the time. And yet opioid misuse is just as prevalent. And if you think about 1 in 19 students across all of the classrooms across the United States, you really get a sense of just how big the scale of this problem is. And of course, the reason we should really worry about misuse of prescription opioids is that actually what's out in the market right now is not typically a real pill that's been prescribed by a doctor and dispensed by a pharmacy. It's actually counterfeit pills. And so as I mentioned before, a lot of pills that are available for sale on social media, targeting teenagers, or that teens may be passing around among their friends or experimenting with are actually not real pills. And they're pills that have been contaminated with fentanyl. And so these are pictures from the DEA. There are lots of these pictures online you can see, and they are all uniformly concerning. So these blue pills, the top panel are real oxycodone tablets, and the bottom panel immediately underneath are fake oxycodone tablets that have been made with fentanyl. Fentanyl is also an opioid, so it also has pain relieving properties. It's also a sedative. And so it can give you a similar physiologic effect to real oxycodone, and that's why it gets sold this way. Unfortunately, we talk about something called the chocolate chip cookie effect, right? So if you're making a batch of chocolate chip cookies, unless you specifically count out how many chocolate chips you're putting in each cookie, when you make a batch of cookies, some cookies are going to have lots of chocolate chips in them, and some cookies are going to have fewer chocolate chips in them. And unfortunately, when you're looking at a pill like this, some pills are going to have more fentanyl in them. Some pills are going to have less fentanyl in them because these are pills that are made without good quality control, right? They're not made by pharmaceutical companies. And so some pills are going to be more potent and other pills are going to be less potent. And that makes it really difficult to know exactly what you're using, especially when you're a teen who may not have much exposure to opioids at all and have no tolerance. And so in fact, the DEA estimates that about 60% of the pills that are available right now for purchase in the counterfeit pill market, about 60% of them contain a dose of fentanyl that's lethal. The middle panel here are Adderall tablets on top, and then the bottom panel underneath are fake Adderall tablets that actually contain methamphetamine. I will say that even though there's a picture of this, this is not something we're seeing a lot of across the US, but has been reported, and I put this up here just to sort of let you know that this stuff exists. But then the right panel is something that is more common. That white tablet is real Xanax, and then the yellow tablet is counterfeit Xanax that again contains fentanyl. The idea here being that fentanyl is sedating, so if you're looking for a tablet that's going to sedate you, like a benzodiazepine would, fentanyl can kind of do that trick as well. And so it's no surprise that if you look at the most recent data from the CDC, now this isn't across the entire United States, but this is really sort of important sentinel information that came out in December of this past year. The CDC did a really good job of telling us a little bit more about the context in which young people died. And the story that I told you about Zach earlier on is actually kind of a really common story going on right now. Among 10 to 19-year-olds who died of overdoses in the United States in 2021, most of those overdose deaths actually occurred at the person's home. 2/3 of the time, somebody else was also home, but often didn't know what was happening. Most of the time, that teen or young person was pulseless by the time emergency medical services got to the house. And naloxone, which we'll talk about as the overdose reversal agent that can reverse an overdose, was given in fewer than 1 in 3 cases. And so this really highlights the extent to which these overdoses happen in people's homes when people are around and could potentially respond. But if you don't respond effectively immediately, there's a high risk of death. Now, let me talk for a second about addiction. And I want to be very clear that patients like Zach, who I told you about before, I don't think had addiction, right? I think he was just experimenting. And so this crisis has evolved in which experimentation can mean death, unfortunately. But there are some young patients who struggle with true addiction or opioid use disorder. And I won't go through each of these criteria, but this comes out of the DSM-5. And these are the criteria that we use when we're trying to figure out if somebody has crossed the threshold from using opioids to actually having a problem with opioids. And I'll kind of clump these together into a few different groups. So there's kind of like 3 overall categories here of criteria that can contribute to a diagnosis of opioid use disorder. Starting with numbers 10 and 11, these are the physiologic criteria. Once you start to use opioids over and over, you'll develop a tolerance to them. And then when you stop using opioids, you'll withdraw from them. And tolerance, just to be very clear, is the idea that it takes more and more to get the same high, or that if you use the same amount that you used to, you don't get the same high. You sort of build up a tolerance. Items 1 through 4 on this list are sort of the second bucket. And this second bucket includes basically loss of control over your opioid use. So you're using more than you used to. You're spending lots of time or money on it. You'll have cravings. You're thinking about them all the time. And then items 5 through 9, or criteria 5 through 9, are the third bucket. And this is when your opioid use starts to cause problems in your regular life. So it's causing problems at school or at home, with your family, with your friends, with your recreational activities. You're giving up things you used to like doing. And so these are kind of the 3 hallmarks of addiction. And I think this is important to point out because let me just highlight one thing that I think gets conflated all the time in pediatric practice. So we've all at various points in time cared for patients who might be on long-term opioids for pain. I think of, for example, a patient with sickle cell disease who has sort of like chronic ongoing pain at various points in time, may be on opioids for a lot of their life. I want to be clear that we shouldn't conflate ongoing use of opioids with addiction or with an opioid use disorder, right? The difference between the patient who is on opioids long-term, like someone with sickle cell disease, where the opioid is treating their pain, is that when that patient takes that opioid, they're able to function better, right? They're able to do the things that they're supposed to do in life, like go to school, engage with their family, have a job. And so opioids are improving their function. And so that's why we know that that's not addiction. It's addiction when opioids are worsening your function. And I want to take a quick moment right now, and as I said, just sort of talk a little bit about the neurologic underpinnings of addiction, because I know when I was in medical school in 2004, 2005, I learned about the nucleus accumbens. If you use a drug, the nucleus accumbens fires dopamine, and that feels good. And that was all I learned about addiction. And that may be the case for some of you. And our understanding of the brain has really evolved in a nice way where I think the brain gives us, or understanding of the brain gives us an understanding of the behavior of addiction. So the way that we conceptualize addiction now is that there are kind of three parts to addiction, or three sort of phases to addiction. And the first phase is this part in blue here, the binge and intoxication part of the cycle. This is the idea that when you use an opioid, you get euphoria, you feel good, and it's sort of the reinforcing part. This is the dopamine being fired in the nucleus accumbens and ventral tegmental area kind of stuff where you have that sort of reinforcing effect. So we understand that. I think many of us have heard that before. The red part, which is the second part of the second phase of addiction, is probably also something that we're all very familiar with. This is the idea that when you don't use, you can develop withdrawal and negative affect. And so things that we see when somebody's going into opioid withdrawal are that they'll have pupillary changes, right? Their pupils will get big, their heart rate will go up, their blood pressure will go up, they'll experience pain, they'll have GI changes like diarrhea. And this is really, in many ways, actually mediated by norepinephrine. So one of the regions in red here that's not highlighted in this figure, but is active, is the locus coeruleus in the brain, which is where norepinephrine gets released. And so the body kind of gets flooded with norepinephrine. Another part that you'll notice in red in the brain here is the amygdala. So patients who are in withdrawal will experience fear and anxiety. And so I think this starts to help us understand why it is that when we have a patient who's admitted to the hospital, who's in withdrawal from opioids or other substances, they often have this sort of like fearful, anxious appearance. And there's a brain sort of basis for this. There's a reason for this. And then the third phase of addiction is this part here that's in green. And this is the part where we have sort of a newer understanding, and it's a more complex part of addiction. And this is preoccupation and it is anticipation. This is the idea that as you start to use opioids more and more, parts of the brain that are a little bit more plastic start to learn around addiction. And so secondary association centers in the brain will start to associate use of opioids with places that you go or people that you're with, and you'll start to experience environmental triggers. And so this is the part of the brain that explains some of the complex behavior that we see around addiction. This is why somebody who's been using opioids for a long time sometimes has to avoid certain places that they used to go because they have these associations in their brain. They may have behavior that to us seems really irrational, right? They might steal money from their parents, or they might, as I said earlier, give up activities that they used to love. And that's because of this sort of brain plasticity and learning that adolescents are particularly susceptible to having kind of hijacked as they get exposed to more and more substances. And so I just like to highlight this because it gives us a really good basis for what's going on in addiction and why it is that we observe some of the behaviors that we do in young people when they've been using. I'm going to pivot for a moment and talk for a few slides about how we as a pediatric workforce can prescribe opioids appropriately. I know we don't always prescribe a ton of opioids, but every once in a while we do. And I think sometimes we have become afraid to do it. And so I want to kind of empower us to do it in the most appropriate and safest way. And I want to observe that, again, when I was in medical school in 2004, 2005, in my preclinical years, I remember learning, and probably many of you do too, hearing things like pain is the fifth vital sign. We should always treat pain. It's cruel and unusual to not treat pain. If somebody has pain and you give them an opioid, they can't get addicted. These were the sorts of messages that were in our ethos. And then some time passed and we started to see a rise in overdose deaths across the country. People were dying from prescription opioid overdoses. And all of a sudden we did this total 180 as a medical workforce, right? We said, there's a crisis here, we need to stop. And so to this day, there are emergency departments in the US that say, we do not prescribe opioids ever, right? There are physicians who will say, I won't prescribe you an opioid because those are addictive. And that also doesn't make a lot of sense, right? Opioids have been around for millennia, and they are a mainstay of medical practice. They are extremely effective at treating certain types of pain. And so what I really want to impart on you is that we should still prescribe opioids, but we should be thoughtful when we do it. And so that's what I want to talk about. And so we'll take a few minutes here. Some questions that I think are worth answering are, what do recent trends in pediatric opioid prescribing rates show? What's the risk after you prescribe an opioid to a young person that they'll go on to have an overdose or experience addiction from it? Which youth are at risk of having problems when you prescribe them an opioid? And then what are steps that we should all take before prescribing an opioid in order to minimize the risk when we do that? So I do want to highlight that opioid prescribing rates in the pediatric world have gone down. And so this is a figure from a paper published last year. And what you can see is by age. So the orange line here is young adults aged 20 to 24. The next highest line are the teenagers aged 15 to 19, that sort of darker gray line. And then down below are younger ages. And the x-axis here ranges from 2006 to 2018 on the right. And what you can see is that, yes, we were prescribing opioids at a certain rate before, like for adult populations. But then from about 2012 onwards, there was a steady decline. And so we actually aren't prescribing nearly as many opioids as we used to. It's really kind of gone down a lot. I'll say, I don't know if that's a good thing or a bad thing. My guess is probably in the aggregate, a good thing. We probably were prescribing too many inappropriate opioids before. But inevitably, this also includes some young people who might have been benefiting from having their pain carefully treated, who are now not getting opioids when they might have done well with one. And if you ask the question, who's actually at risk of having a problem with an opioid when you prescribe it, there are a few different estimates across the literature. This is a study that we did, and what we found is that using large health insurance claims, if you ask the question, among adolescents and young adults who you prescribe an opioid to, what proportion go on to have a problem with that opioid, either addiction or an overdose in the year that follows? Turns out that number is actually pretty low. We found that it was only about 1 in 300 young people went on to have a problem. So, if you're individually prescribing here and there an opioid, these data would say that 299 times out of 300, the teen is going to be just fine and not have a problem with that opioid. So I say that to reassure. Of course, this is the difference between individual care versus a public health problem, because when you multiply 1 in 300 out across all of the opioid prescriptions to the pediatric population across the US, we as a workforce could be creating problems, right? So it's important for us to know what these risk factors are. So it turns out that youth who go on to have a problem with overdose or addiction in the year after being prescribed an opioid, there are some prescription-related risk factors. So it turns out that long-acting opioid formulations are higher risk than short-acting formulations. So OxyContin and MS-Contin are more risky than, say, oxycodone. High daily doses of opioids are associated with higher risk. And then durations of prescriptions lasting more than 7 days are associated with greater risk. And we sort of hear this all the time, right? Like the teen who comes in, has a dental procedure and then gets 1 month of oxycodone afterwards. And I have seen that borne out in my practice. I have seen that contribute to a young person who developed an opioid use disorder. So it absolutely happens, right? But this is a risk factor, is giving somebody too many pills. But maybe even more important than the prescription-related risk factors are actually the individual patient-level risk factors. And so across studies, there have been a few different risk factors that have been identified. Male sex, older age, family history of any addiction. So I want to be clear that it's not just a parent or a sibling who has an opioid use disorder, but Could be an alcohol use disorder, or it could be nicotine use disorder, or it could be, a cannabis use disorder. Patients with chronic pain are at risk of potentially developing problems with their opioid. And then untreated mental health conditions, including mood and anxiety disorders, psychosis, ADHD, and trauma. Now, all of the risk factors that I just listed here, if you look at studies, the odds ratios are like, 1.5, in some cases they're 2, in some cases they're 3. But if you look back and ask, like, what is the odds ratio associated with a young person who engages in other substance use before you give them an opioid? What are the odds that they'll go on to develop a problem with that opioid? Those odds ratios are on the order of like 10 to 20. And so if there's sort of one single risk factor that is probably most predictive of a young person having a problem with addiction when you prescribe an opioid, it's that they're already using other substances. And most commonly, those other substances are the common substances: nicotine, alcohol, and cannabis. And I want to say that that doesn't mean that we don't treat acute pain when it's needed in a young person who's using substances, because they also deserve good pain control, but we do so in a way that's thoughtful and with close follow-up. So let's talk about some best practices. So I'm chair of an AAP subcommittee that's developing a clinical practice guideline on how we should be prescribing opioids safely in cases of severe acute pain. And we haven't yet finalized our recommendations. We're still in the process. We're doing an evidence-based, we're collecting evidence and sort of developing evidence-based recommendations based on an extensive lit review. But I think what you're going to find is that some of the principles that you're going to see listed here are the things that are going to emerge. The first thing is, before we ever even prescribe an opioid for severe acute pain, we should maximize our non-pharmacologic options. And I know we often do this in hospital settings, right? We make sure that patients are getting physical therapy when it's appropriate, that we're engaging in relaxation techniques to help them sort of cope and manage with the pain. And then, of course, we want to maximize our non-opioid medications first, right? So your NSAIDs and your acetaminophen. Because when those are actually dosed appropriately at the upper end of their therapeutic range for a young person, it provides equivalent pain control to opioids. And so you may not even need an opioid. And even if you do use an opioid, you're going to get benefit from these medications being on board in addition to the opioid. You want to conduct an assessment of risk factors, and we just talked about what some of those risk factors were, right? You want to try to identify other substance use disorders. And we'll talk in this discussion in a few minutes about how you identify substance use disorders in young people. You want to identify any untreated mental health disorders, and then again, try to identify if there's a family history, because all of these things put a young person at risk. Again, we still prescribe an opioid in these situations, but we just do so carefully and with close follow-up. And then you want to check the state prescription drug monitoring program, and I know you have one here in California. When you do prescribe, you want to use the lowest effective dose of an opioid of a short-acting formulation like hydrocodone or oxycodone, and avoid using long-acting opioids for acute pain. Chronic pain is a different issue, but acute pain always uses short-acting opioid. You want to avoid co-prescribing other sedatives at the same time. Benzodiazepines are probably the biggest sedative that we need to worry about with drug-drug interactions. And then we want to make sure that we're only offering a short course of treatment with opioids with close follow-up. Typically, 3 days or fewer is enough for most pediatric conditions. Now, there are some very painful surgical procedures, right? I'm thinking of like spinal stenosis, for example, where you're likely to need longer courses of opioids. So 3 days or fewer is not always the magic, but I'd say most pediatric conditions get by with 3 days or fewer of opioids. And you can always be in close communication and prescribe more if you need it. And then when you're working with minors, make sure you're notifying the parents and talking to them about safe storage. So medication should be kept at home, locked up. Ideally, the parent is directly administering the medication themselves to the teen so that they know how many pills are in the bottle and where those pills are going, and they kind of have full control over it. And this is slightly off topic, but I think it's important for us to know as pediatricians that there are FDA warnings around certain opioids. I think sometimes what we do is we think, oh, oxycodone and hydrocodone, those are big medications, right? Percocet and Vicodin. Let's see if we can avoid those by getting by with codeine, which is a little bit weaker, or tramadol, which is weaker and a partial agonist. Actually turns out that this, I think, gives us a sense of comfort that is misplaced, because The FDA, in response to their monitoring of these medications over time, has actually found that we really just shouldn't be using them basically at all in the pediatric population. For children under 12, we should actually never give codeine and tramadol. They can be metabolized in such a way that they contribute to breathing problems or sudden death in young people. And so the FDA has said, just don't ever prescribe them. And yet, if you look at national prescribing data, pediatricians continue to prescribe it. So stop prescribing codeine and tramadol to young kids. For adolescents aged 12 to 18, the warnings are a little bit more specific. The warnings say we should not use tramadol for post-operative pain after removal of tonsils or the adenoids because, again, the risk is for breathing problems. And then there's a warning, which is a slightly weaker warning than a contraindication, saying don't use codeine or tramadol for pain management in patients with obesity, obstructive sleep apnea, or severe lung disease. Again, the issue being risk for breathing compromise. In my personal opinion, I just don't ever prescribe codeine or tramadol really at all, and I just use hydrocodone or oxycodone at the lowest effective dose, and that's probably the safest thing to do. So with that, let me now pivot to talking about evidence-based screening and treatment approaches that we can offer to young people. And we'll talk a little bit about harm reduction and overdose prevention as we do this. So our group has done some studies to try to understand how good we do as a pediatric workforce at identifying problems with opioids in young people and getting young people into treatment. And it turns out we're not doing great. So if you look nationally across the US, the prevalence of opioid use disorder in adolescents and young adults is probably on the order of about 1%. About 1 in 100 young people has opioid addiction across the country. But if you ask the question, how many actually get connected to healthcare? We've looked using both Medicaid and private health insurance data, and very few youth actually get diagnosed and identified as having a problem by a healthcare provider. It's less than half. It's probably on the order of about a third. And then if you ask the question, how many go on to get any treatment whatsoever, that line dips down further. So in this figure, the blue bar means you made it to the next stage of the sort of cascade of care or the continuum of care. And the red part of the bar means you didn't, you sort of dropped off, we lost you. And so among youth who are diagnosed with an opioid use disorder, many do go on to get treatment, but again, it's still an overall small minority of the total number of youth who are out there needing treatment. And then if you sort of go down the continuum of care and ask how many youth get an evidence-based medication to treat their addiction, it's very few. How many youth stay in treatment for at least a month, it's even fewer. And how many youth stay in treatment for 6 months, it's even fewer than that. Such that by the time you get sort of like the far end of this cascade, for a condition that's chronic and relapsing and requires ongoing care with a physician over time, we have a very we do a very poor job of giving evidence-based treatment and keeping young people in care. And like, unfortunately, many things in pediatrics, we have created systems that are contributing to disparities. And so Black youth and Hispanic youth at each of these stages are relatively less likely to progress, indicating that we are not doing a good job of delivering services that are meeting youth where they are and giving them what they need to succeed. So with that as the backdrop, some key questions that I think we should answer. First of all, what constitutes evidence-based treatment for youth with opioid use disorder? How should pediatric providers screen for substance use? Where can providers refer youth who have a problem with opioid or other substances? And then what are some additional simple things that every pediatric provider can do to address this overdose crisis? So the first thing I want to highlight is that we need to make available medications for opioid use disorder. So there are 3 FDA-approved medications to treat opioid addiction. There's buprenorphine, which is FDA-approved for 16 and up, naltrexone, which is approved for 18 and up, and methadone, which is approved for 18 and up. Buprenorphine is the only one that's approved for teenagers, but we often use buprenorphine and naltrexone off-label at younger ages if it's indicated. They just haven't been carefully studied in these populations. Buprenorphine is a partial opioid agonist, so it helps to treat withdrawal and cravings when a young person stops using opioids and then all of a sudden their opioid receptors are sitting empty. Naltrexone is an opioid antagonist, and we'll talk in a moment about why that helps. In brief, it's just helping block other opioids like fentanyl from binding to opioid receptors in the body. And then methadone is a full opioid agonist, meaning that it binds to the opioid receptor and has a full effect, again, treating withdrawal and cravings as it does so. And so these medications are evidence-based because in clinical trials, they treat withdrawal, they treat cravings, they result in better retention in addiction care, including in young people. They're recommended by the American Academy of Pediatrics, the Society for Adolescent Health and Medicine, and other important organizations. And they are typically in most settings offered alongside behavioral health services because many young people are also struggling with mental health problems when they have addiction. But I would just encourage us all to consider that behavioral health services should not be required for a young person to get these medications because these medications are life-saving. They are associated with improvements in survival across studies, both observational and clinical trial studies. And so I would not let the absence of behavioral health services or a young person's poor engagement in behavioral health services prevent you from offering the medication. Having said that, I think teens do better when they have engagement in behavioral health services at the same time. It used to be there was this waiver requirement to prescribe buprenorphine, right? You had to do this 8-hour course to get what we called an X waiver, which would then allow you to prescribe buprenorphine, which was silly, right? You had to take an 8-hour course to prescribe the treatment for opioid addiction, but any one of us could prescribe an opioid without any special training. That's now been fixed. The Biden administration has gotten rid of the waiver requirement. And so any of us right now can prescribe buprenorphine for the treatment of opioid addiction. But of course, easier said than done, right? Prescribing a new medication is not an easy thing to do. And we won't have time to go into the details of it today, but there are great training courses available through this website that I've listed here, including pediatric focused trainings that you can pursue to help find out how to do this. Let me talk for a moment about why these medications work, because as a clinician, one thing that I'll hear from families when I tell them about these medications is, wait, my child was addicted to an opioid and you want to put them on an opioid like Suboxone or methadone to treat their opioid addiction. So you want to treat one addiction with another. And there's a rationale behind this. And it's this, that when you're using heroin or fentanyl or pills, which are all short acting, you use to get high and then you immediately, the levels in your blood kind of immediately drop down because these are short-acting opioids. So you have to use again to get high, to get that euphoric feeling. And you sort of enter this cycle of using over and over. And of course, as you do, it becomes harder and harder to attain that high because of tolerance. And as you do, you start to develop withdrawal and cravings when you're not using an opioid because of those mechanisms we talked about earlier. And so when you're struggling with opioid addiction, when you're using fentanyl and other opioids, which are short-acting, you're constantly cycling between a high, if you can even attain it, and withdrawal and cravings, which feel miserable. And you have very little time where you're actually kind of feeling like a normal person. And so the idea behind using buprenorphine or methadone is that these are long-acting opioids. And so if you wait until someone has started to withdraw from the last time they've used fentanyl or another opioid, and you carefully give them a very thoughtful dose of buprenorphine or methadone, which don't have the same sort of like amplified peaks and valleys, and have a 24-hour dosing cycle, you actually can get someone into this place where they're feeling normal. They're not feeling euphoria from using too many opioids, and they're not experiencing withdrawal and cravings. And this allows them to go about living their regular life because they're not dealing with the sort of like uncomfortableness of withdrawal. Naltrexone is a little bit different. As I said, naltrexone is an opioid antagonist. And what it's doing is it's going into some of those brain regions that I talked about before, like the nucleus accumbens, where you have opioid receptors that are sort of getting into the brain and causing the nucleus accumbens to release dopamine and have that sort of reinforcing effect. The idea here is that naltrexone is blocking that, so you can't experience the euphoria of using opioids. In addition, it also helps to prevent overdose because you can't have fentanyl bind to the same places that cause an overdose. Interestingly, naltrexone has the second effect that happens in some patients, and that is that it can reduce cravings. It turns out the parts of the brain that mediate cravings for various things, whether it's alcohol or food or sex or whatever it may be, are mediated by endogenous opioids, so endorphins. And if you block these pathways, you can sometimes block cravings for other things. And so we'll sometimes use naltrexone in the treatment of alcohol use disorder or binge eating disorder, or for patients who might be engaging in self-harm behaviors that are reinforcing. Naltrexone can sort of blunt the cravings for those various things. So I want to wrap up here in the next 5 or so minutes before we pivot to questions with just talking about some simple things that we as pediatricians can all do and incorporate into our practices. They're kind of easy wins. The first one is to screen for substance use and refer for treatment. Now, maybe not easy because systems often make these things more complicated than they need to be. But we'll talk about what this looks like when it's done right. Discuss overdose prevention and harm reduction with our patients, and then change the language of addiction that we use to reduce stigma for patients and families who are living with these concerns. So there are a few different adolescent-focused screeners that are evidence-based. I presented one here that's kind of easy. It's the screening to brief intervention screener. It can be asked in a pediatric practice. The way that we do it in our practice is we ask it on an iPad that the teen answers privately in their room, and then the answers go into the medical record into a place that we're able to keep confidential for now. Then the clinician knows what the teen is using and what they're not. So actually it takes a lot of the work away from us because we don't even ask the questions. We get to just have the conversation that follows. And I'll say that these sort of iPad-based private opportunities for teens to answer questions actually probably result in the most, they're the best screens when we're not in the room. And so the survey or the screener asks, in the past year, how many times have you used tobacco? How many times have you used alcohol? How many times have you used cannabis? And the question is intentional. It asks about the past year because you want to get at most recent use. And then it asks, how many times have you used, rather than saying, have you ever used, which is easy for a teen to say no to. It's harder for a teen to say 0 if you ask them how many times they've used. So the question is intentionally worded this way. And then it asks about, as I said, tobacco, alcohol, and cannabis. Now, I will say that newer versions of this that have not yet been studied but are ongoing in terms of study right now ask about vaping because obviously tobacco is not what it was when this was first published in 2014. And then you get an answer from the teen about the frequency with which they've used in the past year. Turns out if they haven't used any of these substances, the screener stops there and it doesn't even ask about opioids or cocaine or other substances, because it turns out that epidemiologically, almost every teen that has misused another substance has used alcohol, tobacco, or cannabis first. I say that, and yet I also want to put just kind of like an asterisk on that, because I think of patients like Zach, who, I don't know that he ever used another substance before he tried a pill. And so as the epidemiology changes, I just want to put out there that we need new data as we think about how to incorporate the screening into our practice. And we might ask about counterfeit pills of everybody. That might be something that we want to think about doing. And just the frequency with which a young person uses maps to their risk of having a substance use disorder. This is only true for teens. This is not true for adults who drink a glass of wine with dinner every night. This is for teenagers. A teen who's used a substance either 0, 1, or 2 times in the past year probably does not have a substance use disorder. For a teen who's been using monthly or so, they probably have a mild to moderate substance use disorder. And if they've been using weekly or more frequently, they probably have a severe substance use disorder. And this is important because I think we often hear from teens, oh, I smoke cannabis every day, but I don't have a problem, right? And actually, it turns out that if you do the more complete clinical interview and gather more information, you realize that, oh, there's actually all these ways in which their cannabis use or their other substance use is impacting their life on a day-to-day basis. And then here are just some parameters around those. The negative predictive value of not using or having only used once or twice in the past year is really good. And the sensitivity and specificity of more frequent use for having a substance use disorder is also pretty good. So this is a good screen, is the bottom line. And then, of course, you need to know where to refer a young person who's having a problem. Here, there's the SAMHSA treatment locator, which is an online tool that's available for anybody. And it basically allows you to type in the address that you're interested in and then select various parameters for, oh, I'm looking for treatment for a teenager. I'm looking for treatment that offers buprenorphine. I'm looking for treatment that takes Medicaid. And you can get sort of a Google Map driven response to where some of these treatment programs are. Now I'll say that we've done some studies, in fact, some that are about to be published, showing that these data are not perfect. In fact, they're far from perfect. Often what happens is about half of the places that you'll call either aren't taking patients, or they have wait lists, or they're private pay only, or the information was inaccurate and the phone number doesn't even work. So I just want to say out loud that this is not perfect, but it is a starting point. So the second thing that we can all do is talk about overdose prevention and harm reduction. And this is actually a pretty easy win. When we have a young person in front of us who might be misusing counterfeit pills, or maybe they're using other substances heavily and we're worried that they might try a pill, we should talk about this stuff. We should talk to them about the fact that counterfeit pills and heroin are commonly tainted with fentanyl right now. We should tell them not to use alone, so that if they do overdose, there's someone that's able to respond. We should tell them to start with a little bit to assess its effect, right? If you start with a half tablet or a quarter tablet, you can try to figure out, is that tablet that you're about to try highly potent? And I want to be clear that having these conversations doesn't enable drug use, right? Just in the same way that putting condoms in bathrooms of high schools doesn't make teens have more sex. It just helps them understand that when they do these things, they do it more safely, right? We should tell teens not to engage in polysubstance use, not to mix alcohol and benzodiazepines with their opioids. We should tell them to call 911 in the event of an overdose, to have somebody come and give medical attention. In fact, many states have what are called Good Samaritan laws, here in California included, where if you call 911 and you have drugs on you, you can't get in trouble for having those drugs on you. The police that may come and respond to the overdose can't say, hey, you've got drugs, you're in trouble, right? And then we should carry naloxone. And increasingly, naloxone or Narcan is going to be available over the counter starting this summer. We can also prescribe it. It's typically covered by insurance. And so there are lots of different ways we can get it out into the community, and that's really important. There's also harm reduction principles that we should make available for young people. Even when young people aren't ready or able to stop their substance use, we can offer them other things, right? We can test them for HIV. We can offer them PrEP to prevent HIV. We can offer them hepatitis C testing, and in some cases treatment if they're using heavily and they have hep C. We can offer them syringe exchange services out in the community. We can talk to them about how to inject safely if they're injecting drugs. And again, this isn't enabling substance use. It's helping young people be safe when they're doing it anyway. And the idea behind these services is that they are helping to keep youth safe and build trust with you as a clinician, so that when they are ready to get treatment, they know exactly which doctor they trust to go to. There's also fentanyl test strips, and we're still learning a lot about these. We haven't quite figured out exactly where they fit into our toolkit, but the CDC has come out and recommended them as being available for people, so I want to talk about them. I think in the era of COVID, we've all gotten very comfortable with the idea of the one line means negative, two lines means positive when you dip a strip in something wet. So fentanyl test strips kind of operate under the same principles, right? So what you do with a fentanyl test strip is, let's say you're a teen, you've got a tablet, or you've got some cocaine and you want to try to figure out, is it tainted with fentanyl? What you can do is you take just a small sort of just like a small teaspoon or whatever, take a little bit of the substance, add a little bit of water, mix it together, you dip the fentanyl test strip in, let it sit for a few seconds, and then you lay it flat and you wait a couple minutes and you see if there's one line or two lines. Two lines meaning fentanyl is present, one line meaning fentanyl is not present. Caveats, we've got a lot of studying to do to understand how these fit into our repertoire. Do young people understand how to use them? How do they use them? Does it keep them safe? But it is an available tool that we can make available. And I know in Massachusetts, our public health department just ships all of us clinicians fentanyl test strips to distribute in our practice if we want to. And so you may have similar services available here. And so the last thing I want to highlight is just how we should change the way that we talk about addiction to reduce stigma for families. And, when we're in our healthcare settings or when you're reading the newspaper, you come across all of these words that are really sort of unattractive and kind of terrible ways to talk about people who are living with a chronic medical condition, right? You'll see in the news, junkie, druggie. I hear all the time people talk about addicts. And just in the same way that we don't say, down in room 101 is the 17-year-old diabetic. We say, in room 101 is a 17-year-old boy with type 2 diabetes, right? We want to put the person first and then the condition second. And we should do that with addiction as well. There's other terms that might not actually seem that harmful, terms like substance abuse. Actually, turns out that some carefully done studies have shown that when clinicians, and I believe probably especially pediatricians, read the word abuse, it kind of evokes different things for us, right? Like when I hear the word abuse as a pediatrician, I think about physical abuse, emotional abuse, sexual abuse. Misusing a substance is not in that camp, right? But I think these negative associations can happen. And some studies have shown that when you document the term abuse in the medical chart, patients get treated differently than if you use another word like substance use disorder. So I'd encourage everybody to just drop the word abuse if you can. There's a few other terms here, maybe most pertinent for us as pediatricians. This is this last one. You'll often read about babies with opioid withdrawal syndrome being described in the newspaper as babies being born addicted. Imagine being a parent and like, you know, who may have gone on treatment for opioid use disorder, may have been on methadone or buprenorphine and doing everything to support your recovery. And then someone says your baby's addicted when they're born. That's just really hurtful. And so the American Academy of Pediatrics has a statement around all of this and is really saying we should, you know, really move away from some of these terms that you'll hear. And with that, I'll stop. And I think we've got a few minutes for questions. So thank you so much.
Thank you very much. That was terrific. There are so many lessons we can learn, and there are some questions here. We'll start off with a question from the audience here. Yes.
Thank you so much. That was an excellent and very informative talk. I'm Carrie Rasbach with the Pediatric Residency Program. And just first of all, a shout out to our colleagues down at Santa Clara Valley Medical Center who have started a Suboxone initiation program for adolescents, because adolescents in our community were having difficulty accessing good treatment. So our residents have exposure to that in that setting. But we're also in pediatric residency thinking about incorporating more mental health training. And I'm curious what you would recommend as sort of the ideal training for a pediatric resident to gain a better understanding of how to treat these patients or assess these patients in their setting. Should we have them rotate with addiction medicine? Is there another approach that we should use?
Great. So I think that's a fantastic question. And I think it really depends on the setting, right? So most hospitals in the year 2023 that have academic training programs will have some kind of addiction treatment service, but it's very adult focused, right? So it's a great way to learn about how do you initiate buprenorphine, or how are these medications used? What is methadone? How do you get patients on methadone? Those are skills that we don't get taught in medical school or residency very readily. So I think those are good opportunities, but it's worth knowing that that's not going to be youth focused at all, right? That how do you talk to a teen about what the medication is and how do you use it? How do you talk to their parents about what addiction is and what treatment is going to look like and how long you should be on the medication for and what does it look like to come off the medication are very unique sort of pediatric questions that you're not going to get from an adult-focused addiction treatment service. So I think ideally, you kind of have a little bit of exposure to both. I think the best opportunities are when you have passionate providers in adolescent primary care who are doing this as part of their overall practice, because then they're potentially not just treating addiction, but also identifying depression and anxiety and treating it and getting people referred to where they need to be and addressing their other health problems kind of all in one place. But it's not easy to get this in education because it's still, even though we know it's a huge problem nationally, it's still sort of low volume enough in many of our pediatric health centers that it's hard to get an entire residency program of residents exposed to this. But I'm happy to talk more about it.
Thank you. We're going to take one question, well, a couple of questions from the chat as well. A question from Nicole McKenzie. Do you see a role for making fentanyl test strips, training and availability in high schools? And also, do you see a mechanism where nasal Narcan can be made widely available to the population at large?
Great questions. So on the fentanyl test strip question, I think fentanyl test strips can be really powerful in certain situations, but I caution, I don't know that they're going to be this sort of amazing intervention that's going to change everything, right? Like if you think about a patient like Zach, or somebody who's, might be using another substance that could be tainted with fentanyl, they might use it as a way to keep themselves safe and understand what's in it. But there are probably also some young people who might be actually actively seeking out fentanyl. Or in this era in which the DEA has told us that 60% of all counterfeit pills contain a lethal amount of fentanyl, like we probably should just be telling people, like, here's how to keep yourself safe from pills writ large, rather than saying, if you do get a pill, test it, right? It's sort of giving you information you already knew. So I think there are specific situations in which we should absolutely use them to empower young people, but they're probably not going to solve every sort of scenario. And I think naloxone should be everywhere. And in fact, it's increasingly in schools. LA Unified School District is now the largest school district in the country to make Narcan available in every single one of its schools, even the elementary and primary age schools. Recognizing an overdose can happen everywhere, but more than just having it available, we have to talk to people about how to use it, how to recognize the signs of an overdose, and remind them to call 911 so people get attention when they need it.
Questions from this audience? Yes, Lauren.
Hi, I'm Lauren Wozniak, the third-year Adolescent Fellow. Thanks
Hey,
for that
Jen.
awesome talk. When you mentioned that Zach had bought the pills on social media, I'm wondering what sort of advocacy we as pediatricians can do to work with the social media companies to put some guardrails on this and work towards safety with these social media companies.
Yeah, I have to say the social media companies have been trying to take this on. They recognize that this is happening on their platforms, and they've taken some measures, but the tension is that social media companies are fiercely protective of people's privacy, right? And so they as much as they want this to stop happening on their platforms, they also don't want, from their business standpoint, don't want to be in the position of revealing people's identities to law enforcement. And so there's a tension here. And so it does need the advocacy that you're describing. And I know that folks in adolescent medicine here are doing some really interesting work around social media that I think is really important to be done. I think my stance is we should probably ally with social media to try to think of ways that we can put guardrails in place that are just preventing this stuff from getting teens in the first place on the platform, age restrictions, certain content restrictions, but it's complex work and it probably involves a lot of nuance and partnering with the companies instead of, railing against them.
Okay, one more question because it's 9 o'clock. Question from Dr. Yen, Sophia Yen. What percentage of opioid prescriptions are written by surgeons versus PCPs?
Hey, Dr. Yen.
That's a Dr. Yen question.
Most are actually from surgeons in the pediatric age range. And in fact, most are for dental procedures. And that also is unfortunately where sort of the high volume, high dose, long duration prescriptions are happening. So, and this is not to lay blame, this is just sort of epidemiologically what's happening. So we're actually, many of us are kind of trying to partner with the dental community to try to help address this.
So it's 9 o'clock and we have lots and lots of questions. Dr. Hadland will remain behind to answer any questions, but this really was very informative. I think many of us know people who have lost someone because of opioid use disorder, and that many of them were just exactly like Zach, people who were experimenting. And I think we can do a better job. So we've learned a lot from you. Thank you, Scott.
So much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.